Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video is missed by anybody.
So I welcome one and all for this class today, and the class is a very, very important topic, which is hypertension in pregnancy. And I cannot give you a further introduction about hypertension in pregnancy. You've seen patients, you've dealt with patients, people who are working in tertiary sectors, which I think 90% of you have seen patients with preeclampsia, severe preeclampsia, eclampsia, and have managed them as well. So you know how common this condition is and how important this condition is, and you will definitely get one, such case in your exam. At least one of you is definitely going to get a hypertensive disorder case in your Viva, and will definitely maybe throw in a question in at least paper 1, 2, 3, or 4 on something related to hypertension. Okay, so I have tried to touch upon all the important aspects. It's a very, very lengthy topic. I might have to, stop somewhere in between and take the class next week as well. It's that important. But at the same time, I have tried to include everything which is latest. This particular presentation has included the FOXI guidelines and the recent changes in the terminology, in the management, and in the definitions of hypertensive disorders. Okay, so I've included that as well, the latest newer management and the latest definitions I've also included, and I've also included the changes in the management and the monitoring profile. All right, so let's begin today with hypertension in pregnancy. Let's start with the classification. So very old classification, somewhere early 1990, we used to study about PIH, gestational hypertension, mild or severe preeclampsia, and that continued till 2013. Okay, so we used to call it, PIH basically, and now we call it mostly mild or severe preeclampsia that continues. Then you have preeclampsia, eclampsia syndrome. Okay, then preeclampsia with severe features. Okay, so this is, the latest. So you do not really talk much about the PIH. Now it's mostly about preeclampsia, eclampsia syndrome, or preeclampsia with severe features, something like that. And why so is because, see, there was earlier, reasons behind these changes: failure of the healthcare providers to appreciate the multi-system nature. Preeclampsia is not only associated with the proteinuria alone. See, earlier on, there was a high dependence on proteinuria. This was a rigid criteria of dependence on rigid diagnostic criteria. That is the dependence on proteinuria. Secondly, preeclampsia is a dynamic process. Okay, so we need to disassociate it with just proteinuria alone. It affects so many organ systems. Okay, so here is just a small, etiopathogenesis. See the level of its involvement of different organs. So definitely it starts from maternal vascular. It's a maternal vascular disease, isn't it? Also faulty placentation, excessive trophoblast invasion. So finally, all these things, they culminate into what? Reduced uteroplacental perfusion. Okay, so there are genetic factors involved, immunological factors involved, inflammatory factors involved. Okay, and finally, it leads to this three important aspects. First, it causes vasoactivation. So there is vasospasm, and not just vasospasm, there is also vasodilatation in a way that there is leaking of the capillary. The capillaries become leaky, as a result of which there is more of leakage of the fluid from inside the compartment of the vessels, and it goes into the extravascular space. So the patient has edematous, but it's not running inside the veins or the arteries. Okay, so the actual fluid is not intravascular, it's extravascular. Correct? And because of that, you have oliguria, liver problem, abruptio, seizures, also multiple organs are being involved. Kidney is being involved, brain is being involved, placenta is being involved. Since there is so much of edema, proteinuria, again, urine, hemoconcentration. So all these problems, they start like DIC, hemoconcentration, problems related to hemoconcentration, correct? And then, of course, you have these noxious agents, you have free radicals, they are also increase because this is a pro-inflammatory process. So there is activation of the coagulation cascade, thrombocytopenia. So this is the worst that can happen. So when you're thinking about preeclampsia, remember to put your mind, why do we go in for a LFT, KFT, sometimes even MRI brain? Because this is the broad spectrum of the effects of preeclampsia. Okay, so when a patient is going towards severe preeclampsia, you've got to be very, very alert. You've got to be alert with the lungs. You've got to be alert with the kidney. You've got to be alert with the edema. You've got to be alert with the urine, proteinuria. You've got to be alert with the edema in the brain. Seizures, they actually start from there. And you've got to be very, very alert with the capillaries, because they are the ones which are causing the leaky capillaries, are causing the edema. The leaky capillaries are causing proteinuria. The leaky capillaries are causing the hemoconcentration. They are causing thrombocytopenia. All these problems, they are being caused because as an effect of preeclampsia. So this is what I wanted to just give you as a small pointer right in the beginning of the class. Now, so after this, so what I wanted to impress upon you is that we should not just depend on proteinuria alone. It does not matter if the patient is having a very high blood pressure along with severe headache or epigastric pain. Do you think she's not severe preeclampsia? She is. If there is no proteinuria, that's not a hallmark. So the Task Force ACOG 2013, it recommended its classification with few modifications, like, what is it called? Gestational hypertension remains where it was. So here you have without proteinuria and during pregnancy after. So these are two important things, after 20 weeks and without proteinuria. These are two important things. BP returns to normal after 12 weeks, postpartum, and only a few percent, 1/4 of the people, they progress to preeclampsia. Correct? Then there is something called as preeclampsia-eclampsia syndrome, maybe preeclampsia with severe features. These are overlapping. But exactly as per ACOG, I'll tell you what they have said. They have said preeclampsia, the systolic blood pressure 140, diastolic more than 90 after 20 weeks of pregnancy with proteinuria and or high BP in the presence of severe features or end organ damage is called as preeclampsia-eclampsia syndrome. And then comes preeclampsia with severe features. So here, see, this is the one which has 140, 90 and above. Correct? Here we are going preeclampsia with severe features 160, 110 and above. On 2 occasions, 4 hours apart, while the patient is on bed with proteinuria more than 2 grams in 24 hours. So this is even more dangerous. Correct? And here, in recommendation of syndromic approach, task force has eliminated the dependence of diagnosis of proteinuria. So if I'm saying that I have to have a syndromic approach for preeclampsia, I don't need the dependence on proteinuria. I hope by now you all know about it already. If you've got any doubts, guys, this is the time to ask me the questions. And I'm looking at my chat box every now and then to see that if you have any questions. Okay, I will keep going forward. You can keep asking the questions in between. Okay, because that's the purpose of a live class. Correct? So you can tell me about what are the different severe features of preeclampsia. Quickly, guys. So who all are there in my class today? Let me just see them, and you can answer in the chat box. So yeah, Bhavna is there. I've got Meghna today. Then I have Ratish. Please, guys, you can answer these questions. So tell me the severe features of preeclampsia, which will be called as a preeclampsia with severe features. When should I be concerned? Yes, we can start writing now. So I have a few severe features in mind, and I want my students to give me an answer. Yes, Lavanya, great. So I'll wait for your answers, and I would want you to tell me. Yes, okay, Lavanya. So you say you started with the difficult one. You've gone on to the lab parameters. You say that severe preeclampsia with severe features means creatinine more than 1.1. Okay, deranged LFT, thrombocytopenia, severe headache. Excellent. So there are many. Okay, I have a whole table on that. Where's that table? Oh, great. Somewhere here. Yeah. Okay, it's time to share. So these are the actually alerts. Okay, let me see what So mostly thrombocytopenia. So these, remember guys, according to the task force ACOG, they say that preeclampsia, because this is their definition. Okay, preeclampsia with severe features means thrombocytopenia less than 1 lakh, pulmonary edema, new onset cerebral symptoms or visual symptoms, impaired LFT, new development of renal insufficiency. That means, yes, Lavanya, you are right, serum creat more than 1.1. Eclampsia. Seizure that cannot be attributed to any other causes. So these are few severe features of preeclampsia with severe features. So this is the one. Like I said, thrombocytopenia less than 1 lakh. Then you have pulmonary edema, or you have cerebral symptoms, or you have visual symptoms, or you have impaired LFTs, or impaired renals, you can say insufficiency, or impaired renal functions. At least serum creatinine more than 1.1, like Lavanya said, and eclampsia. So the other features, let's talk about that. So fundus features or epigastric pain, they're not finding a place over here. Okay, but again, it's overlapping. You can still speak. Nobody's going to cut your marks on those. But I'm talking and elaborating right from ACOG 2013. Okay, like they have said. Okay. This is different from my, see, everybody who's taken my notes, all those of you who've got my theory course with them, it is definitely very elaborate. Today's class is also not as elaborate as the notes are. Excellent notes they are, and they are all on 2019 NICE guidelines, associated with NICE guidelines 2019, and with all the latest screening methods and all. This is actually a newer management process. Once you've read those notes, then read this PPT of mine. You'll be able to understand it better. Or you'll add one more thing to your already the understanding. Plus, there'll be a little bit of revision as well. Now, what is chronic hypertension? So we spoke about preeclampsia in detail. We spoke about what preeclampsia is, what is the pathophysiology, what is the etiopathogenesis, what is preeclampsia mild, I won't say mild, but what is preeclampsia alone, and what is preeclampsia with severe features. So you saw that, yes, end organ involvement. Thank you, Usha. Good evening, and welcome to the class. I'm very happy when Usha is around. So chronic hypertension means either mild or severe, okay? But it would be before pregnancy. So this is the buzzword, before pregnancy or before 20 weeks of gestation, correct? Persistent 12 weeks after postpartum, and high-risk factors associated are age more than 40 years, hypertensive since the past 15 years, known case of diabetes or a renal disease, cardiomyopathy, connective tissue disorder. She's having some other chronic disorder, mostly kidney disease, or this SLE, or maybe lupus anticoagulant, or cardiomyopathy, or some other diabetes. And then you have superimposed preeclampsia. That means acute newer onset of proteinuria or increase in proteinuria of a person who's already having proteinuria. That's the superimposed preeclampsia. I hope you know these definitions. These are MBBS levels, and I'm not going back to them.